This session is titled Unique Challenges in Anti-Coagulation. Unique Challenges in Anti-Coagulation. I'd like to request our chairperson to take this forward, and that is Dr. Arvind Kohli. Over to you, Doctor.
Good afternoon, and as the name says, it's unique challenges in anticoagulation, because we are going to listen from the speakers about the various subset of patients where all of us think many times before proceeding or maintaining anticoagulation. And straight away I'll invite Dr. Indra Agarwal, and approach to anticoagulation in children, very important. Please.
Okay. Good afternoon, and I'd like to thank the organizers for giving me this opportunity to speak amongst a forum of primarily surgeons, which is an unusual situation for me. So I think we go by that. Okay, I need to move slightly. So my talk will cover a few case scenarios, the definition of VTE, some epidemiology, clinical signs and symptoms, diagnosis, clinical management, and the duration of treatment. So I'll start with some case scenarios which we commonly come across. An 8-year-old child with poorly controlled nephrotic syndrome presented with a relapse. He had a previous history of a gastrointestinal infection just prior to admission, and the child was edematous, so he was started on diuretics. On day 4, he developed acute severe hypertension and a headache. When an MRI was done with A and V, this showed a severe extensive thrombus in the distal and the superior sagittal sinus, and which also extended to the transverse sinus and sigmoid sinus, and he was started on Clexane. The second child, a 9-year-old child who presented with a facial swelling, which was actually extending around the eyes and the neck, and was diagnosed to have preseptal cellulitis and a parapharyngeal abscess. The blood culture grew a methicillin-sensitive Staph aureus, so this child had disseminated sepsis, started on antibiotics, but on the 3rd day developed a lower motor neuron palsy. An MRI done showed cavernous sinus thrombosis. Another younger child, a 1.5-year-old child with a cyanotic heart disease, tetralogy of Fallot, also presented with a gastroenteritis and dehydration, and on the 3rd day developed left-sided seizures and decrease and paucity of movement in the left lower limb. He had a very high PCV and a high platelet count, and an MRI done again showed cortical venous thrombosis. Another 10-day-old child came with sudden onset of anuria, and he had lethargy and poor feeding. On an examination, the child's kidneys were bilaterally palpable, and when we did a CT, we showed that there was extensive thrombosis of both the renal veins. So this child required a peritoneal dialysis and anticoagulation, but however, it did not improve. The anuria persisted, and this child was then went home DAMA with a suspected, probably inherited thrombophilia like protein C or protein S deficiency. So these are some of the common scenarios that we see in our setting in children, though not very common, but we do see them from time to time. So this definition is very well known to this august audience of venous thrombosis is the formation of a semi-solid coagulum within the venous system. And it may be superficial or deep, and of which the deep vein thrombosis is very common, and pulmonary embolism is another situation that we see quite commonly. Now, what is the difference in children? Incidence is actually quite rare. We don't see it very often, but the causative factors are often multifactorial. And the other thing is it has a bimodal distribution. It is common in neonates, and it is also common in adolescent children. And hospital-acquired VT is another situation which we see quite often associated with critical illness. And incidence, once it occurs, it increases the mortality, it increases the cost of treatment, the duration of treatment, and the outcome. And many other complications also come in, like limb ischemia, anticoagulation, associated bleeding, etc. But then why is it rare in children? Well, for one reason, they have good antithrombin activity. They have reduced thrombin generation, and there's an increased ability of the alpha-2 macroglobulin in inhibiting this thrombin. The other very important factor is that they have no endothelial damage, unlike adults who have lots of other chronic illnesses like diabetes hypercholesterolemia, hypertension, use of OCPs, or even smoking, which would increase the risk. And unlike adults, in children, it is always provoked. So often multiple risk factors are involved. It's not only one factor that increases the risk. Amongst these, the most common is the use of central venous catheters. But along with them, there may be trauma, surgery, drugs, critical illness, immobilization, which may play a big role. Along with that, we also have congenital thrombophilias that may be there. And whenever the virtue of triad is any factor in this triad is affected, there is a risk for thrombosis. So something about CVC, central venous catheters and thrombosis, it's very common in children, especially newborns. It may be seen in 90% and 60% in older children. And the factors which predispose to this are things like chemotherapy, TPN, long-term antibiotics, and infection itself can damage the endothelium and increase the risk. And here anticoagulation is required, which is given through the catheter itself. And after 2 to 3 days of treatment, this catheter is removed and also requires frequent monitoring. The other situations that are common are infections like sinusitis, mastoiditis, etc., inflammatory disorders like SLE and rheumatoid arthritis, trauma, surgery, immobility, nephrotic syndrome, as I already gave an example, and cancer chemotherapy, where again multiple factors are involved. This is a clinical presentation which you see often acute limb ischemia is seen with swelling and discoloration. Neonates, especially, it can be quite severe where there's associated thrombocytopenia, purpura fulminans, skin necrosis may be there, and maybe even loss of extremities, the formation of gangrene. Headache, visual impairment, and abducens palsy is another common presentation in older children. Inherited thrombophilias are quite common in children, and they may present either very early in life or in adolescence, and we suspect it if there is a history of, already a family history of such a condition. So some of this has been already spoken about. It could be a deficiency of the anticoagulants like antithrombin and protein C and S, or it could be an effect of a gain-of-function mutation of the procoagulant factors like protein factor V laden, prothrombin G2021 0A mutation, or the MTFHR mutation associated with homocystinuria. The clinical features may depend on which part of which area is involved, the duration of thrombosis, and therefore the severity of presentation may vary. As you can see, pain and edema are really the most common symptoms that may be present, and it is a high index of suspicion and the presenting limb, the risk factors that might help you suspect this condition. The complications that occur are limb ischemia. Pulmonary embolism is not very common in children but can occur from time to time, anticoagulation associated bleeding, and there may be the recurrence of clot, and clot progression may also occur. And you have also the post-thrombotic syndrome where there's pain, swelling, and various other chronic gangrene may occur. And when it becomes chronic, then there is really a reduced quality of life in these children. Investigations include the standard investigations of CBC and the PT-PTT. Dimer is already talked about. We don't really have good reference values in children, so it's not always so useful. What we commonly use is a Doppler ultrasound, but it is cheap, easily available, but probably often requires the cooperation of the patient, so sometimes it can be a little difficult in young children. So the gold standard for us, even CT venography is used and MRV is used. CT is good because it is a short exposure, but the risk of the nephrotoxicity of the agents are a thing to consider, whereas MRA and V is useful, but it requires general anesthesia as most children don't cooperate. So for the specific thrombophilias, as we said, mutation studies are available, and we can do functional assays of thrombin, antithrombin 3 and factor laden factors. And for antiphospholipid antibody also, we talked about the ELISA test and doing the lupus anticoagulation. So coming to the goals of treatment, we want to make sure that there is no extension or embolization of a thrombus that is there, and to prevent recurrence or pulmonary embolism, and to prevent long-term complications. So the three modalities available to us are no very different from adults. We have unfractionated heparin, we have low molecular weight heparin, and you also have the oral vitamin K antagonists. The direct oral anticoagulant agents, really there are not much information on children and therefore are not commonly used. Unfractionated heparin it has to be given as a continuous infusion. You give an initial bolus of 75 units per kg, and then you follow it up with a dose of about somewhere between 20 to 30 international units per kg, depending on the age of the child. And if there is excessive bleeding, then the anticoagulant given is to reverse bleeding is protamine. The advantage is it is short-acting, so it can be given if acutely required in a child, and also if you need urgent surgery, it can be stopped immediately. However, it has some disadvantages that it has unreliable pharmacokinetics and therefore has to be monitored very closely. There is a risk of osteoporosis, and there's also a risk of HIT, which can often, the heparin-induced thrombocytopenia, which we may see from time to time within a few days of starting treatment. In these situations, you have to stop treatment and then start the direct thrombin inhibitors like argatroban. The low molecular weight heparin, like Lexane, is probably the most useful. Just have a few more slides. The most useful drug that is used by us. It can be used both in the acute situation and in the chronic situation. And the advantage is that doesn't require too much monitoring. It can, factor 10 SA levels can be done, but really not routinely required as much as it's required for heparin. And younger children have higher doses compared to older children. Vitamin K antagonists are also, warfarin is very, very often used by us. The biggest advantage is that it is given orally. You start with a low dose of 0.2 milligram per kg, but here again requires very, very close monitoring because you need to maintain the INR between 2 and 3. And if there is excessive bleeding, then we'll have to stop the drug, give vitamin K, and sometimes also need to give FFP. As I mentioned, direct oral anticoagulation, there's very, very little information available for us for children, so we don't really use it. And the duration of anticoagulation, as already was discussed in the previous session. So if it's the first episode, generally if it is reversible, it's a reversible cause, we give it for 3 months. If it is there's a chronic cause that it's associated with, we may have to give it longer, till as long as the risk factor exists, so it may be even longer as 6 months. And if it's a very chronic cause, the repeated exposures, then we may have to give it for 6 to 12 months. Similarly, for recurrent VTE, also we have similar guidelines. The transient risk factors would be things like central venous catheters and infection. Persistent factors would be things like nephrotic syndrome because there's risk of recurrence, or if the patient is on ongoing chemotherapy. And there's also idiopathic or unprovoked VTE where you need to give it for 6 to 12 months. So basically, we start with low molecular weight heparin in most situations and shift over to warfarin. But in some situations where you want very rapid reversal, you may use unfractionated heparin. And the duration for idiopathic is 6 months. For secondary, it may be 3 months. And if it is recurrent and idiopathic, then we may need to give it quite long, and including it, the possibility of using it lifelong. We also do use it for prophylaxis in some situations where, depending on the etiology, if there's adolescence, if there's a need for prolonged immobility, if there's the patient is on exogenous estrogens, there's a recent trauma, obesity, and poorly controlled SLE and diseases like that. Amongst these, the low risk, they may be stratified as those who have early and frequent antibiotics. The high risk are those who are need low molecular weight heparin. So the contraindications are active hemorrhage, thrombocytopenia, and hypertensive crisis. And also if there's a patient has been on having high intracranial and intraocular pressure. So our take-home message is there's a lot more to be still learned in this area. We need better drugs for children, and the children also have problems with frequent testing when we start the children on warfarin. So the pain that's involved with it, frequent testing, and they all pose a high risk of bleeding. So we really look forward to having better drugs with better efficacy, better safety for children, which is more also convenient for use in children. Thank you.
Thank you very much, ma'am, for an excellent presentation. And we'd like to have questions at the end of the session. Continuing, we'll have anticoagulation in chronic kidney disease. How much is too much? Dr. Pranay is here. Dr. Pranay, please.
Good afternoon. At the outset, I'd like to thank the organizers for inviting. And it's an excellent time to meet after 2.5 years almost. So I'll be talking about anticoagulation in CKD. It's an extremely, I think, unaddressed problem, and it's a major health issue. I've got no disclosures to make. So coming to the background, so we know that the prevalence of CKD is about 8 to 16%, and because of the associated illnesses, this is only going to increase. And the CKD 3, 4, and 5, there's about 6% prevalence in the world right now. And this is also going to see a market increase in the next few years. VT, atrial fibrillation, and arterial thromboembolism, these patients are at a higher risk than the general population. For example, there are 2 to 3 times risk of having VT rather than the general population. Atrial fibrillation in these patients ranges from about 20% in pre-dialysis patients to almost about 40% in dialysis patients. So there is going to be an increased use of oral and parenteral anticoagulants in these patients. And we will also be seeing these patients more and more in the coming few years. So it's very important to be made aware about the use of anticoagulants in this cohort of patients. So what are the challenges of using anticoagulation in CKD? As we know that CKD 4 and 5 are usually excluded from most landmark studies like the RELY, ROCKET, and the Aristotle studies. CKD 4 and 5 were not included in it. Coming to the various societies, there is no consensus among the various societies regarding the use of these drugs in CKD 4 and 5. There are many variables like the diseases. CKD is not an isolated disease. There are usually 2 or 3 other illnesses associated with it. Patient and treatment specific variables are also there. There are also significant drug-drug interactions as these patients are on numerous drugs. And there are no bleeding and thromboembolic risk scores which take CKD or renal failure into the scores as well. So there is a paradox of hypocoagulability versus hemorrhagic risk. These patients in the initial part of CKD are in a hypocoagulable state, and as we move towards the latter part of CKD 3, 4, 5, there are increased risk of hemorrhage. So the increased hypocoagulability is because of uremia, which leads to inflammation and prothrombotic changes like increase in von Willebrand factor, fibrinogen, and factor 8, increase in antifibrinolytic factors, and coagulation and platelet activation in extracorporeal hemodialysis. There are associated with hemorrhagic risks as well. As we said that as you go ahead to the more advanced forms of CKD, there is increased bleeding risks. They have a 6 to 7% risk of intracerebral hemorrhage. There is a reduction in platelet adhesion and aggregation. Anemia in this patient also predisposes to increased hemorrhage. There is frequent use of heparin in hemodialysis, and these patients are on multiple antiplatelet drugs as well, which can also cause interaction. So coming to, we'll go through the various drugs and just talk in brief about them. So unfractionated heparin is probably something we've used for a very long time. It's cleared primarily by the reticular endothelial system. But once that gets saturated, it's really excreted as well. So depending on the dose, it has a half-life of 30 to 150 minutes. And in patients who are in moderate to severe CKD 3, 4, 5 are more prone to over-anticoagulation. Even though it is not primarily a renal excreted drug. The ESSENCE and the TIMI trial, they basically showed that your creatinine clearance, if it was over 30 ml per minute, the bleeding risk was 1%, and if it was less than 30 ml per minute, so it is 6.6%. So this was both with unfractionated as well as low molecular weight heparin. So that has to be kept in mind. So the advantages are, it's a short half-life, and we have a reversible agent in hand, which is protamine sulfate. Low molecular weight heparin, enoxaparin is the most studied drug out of the low molecular heparins in renal dysfunction. And we'll have to use a targeted anti-A level in these patients. So 1 to 2 if you're using the drug once a day, and 0.5 to 1 if you're using it in 2 doses during the day. These drugs have also, according to the stage of CKD, as you go down, you have to lower the dose of the drug. So if you're in CKD 5, you need to go to 0.3 to 0.4 mg per kg in these drugs. Dalteparin, there are no dose adjustment required till creatinine clearance of up to 30, but you have to monitor 10 A level. Not a lot of studies have been done in this drug in CKD patients, especially 4, 5, and on patients who are on HD. So vitamin K antagonist warfarin, this has been used for years. So this helps in individualized treatment, and you have to really pay attention to these things when you use this drug. So you'll need to use lower dose requirements. If your creatinine clearance is 30 to 59 ml per minute, you will need a 10% dose reduction. If it's less than 30, you would almost go 2 times of that to 20% dose reduction. So the labile INRs are very important. These patients have supratherapeutic INRs, which leads to greater bleeding. Warfarin calciphylaxis and warfarin-induced nephropathy is also seen in these patients, and that has to be kept in mind. And these drugs may have to be stopped if you find out that these entities are taking place. You would want to maintain a INR of 2 to 3 or a time and target range of more than 70% for these drugs to be effective if you're going to start them. So nowadays, these NOACs are being used. I would just like to focus on the renal excretion. As you see that dabigatran has about 18% renal excreted drug. So automatically that tells you that it's primarily not a very safe drug to be used in CKD patients. Rivaroxaban is about 35, apixaban is the least with about 25%. Apixaban is factor 10A inhibitor, and it was specially studied for creatinine clearance from 25 to 30 in the Aristotle subset which was done. And they also said that a 2.5 mg BD dose can be used if your age is more than 80, weight is less than 60, and your creatinine is greater than 1.5. A subset of the study, which I said, has fewer major and non-major bleeding events than warfarin. And in 2014, it was approved by the FDA to be started on patients on hemodialysis as well. So the only NOAC which has been approved to be started on patients on hemodialysis. Rivaroxaban also has a adjusted dose. You can come down to 15 mg per day for patients with creatinine clearance less than from 15 to 50 milliliters per minute. It is avoided in CKD5 and in patients who are on hemodialysis. Dabigatran, it is 80% renally excreted and is to be used with caution when the creatinine clearance is less than 30. However, it's the only NOAC which can be, if you can do hemodialysis, if you have overdosed on this, and it has a reversible agent as well, which is used. So just like to focus on this slide, as you come down to the creatinine clearances under 15 to 29 and lower than that, the only two drugs in which all these societies, which is the AHA, ACC, HRS, CHEST, and KDIGO, they agree on warfarin and apixaban only are the two drugs which can be used safely in the more advanced forms of CKD, and that needs to be kept in mind. In conclusion, I think there are more questions than answers in this. A lot of the data is from patients with atrial fibrillation and not with VT. So further studies in patients with VT need to be done. Further research is needed, and dynamic and individualized treatment with proper monitoring is the key in these patients. Thank you.
Thin balance between hypercoagulability and bleeding, that is the crux, and very nicely presented. Questions at the end of the session, please. We move on to the guidelines in anticoagulation in cancer. Dr. Singh will be presenting.
My topic is on anticoagulation in cancer. It all started with Professor Trousseau's finding, who found out that I've always been struck with the frequency with which cancerous patients are affected with painful edema of the superior and inferior extremities in 1865. But it was an irony that he himself was diagnosed with gastric cancer and died soon after. But there was the breakthrough in the finding of deep vein thrombosis and venous thromboembolism in cancer. As you can see, about 20% of patients with venous thromboembolism occur in cancer, and of all the cancer patients, 20% will have symptomatic venous thromboembolism, and venous thromboembolism is the second leading cause of death in cancer. And you can see that the multiple factors which play a role in deep vein thrombosis and venous thromboembolism in cancer, starting with the stasis caused by prolonged bed rest with cancer patients, especially occurring in the later parts of their life in cancer, and the more procoagulant factors released from the cancer cells and the inflammatory process which goes on in advanced cancer, and along with that, the endothelial damage caused by chemotherapy, which can also lead to a higher risk of deep vein thrombosis, venous thromboembolism. And it is also related to the site of cancer, especially in gastrointestinal cancers like pancreas, and the histology of the cancers, and in biomarkers like the elevated platelet counts before chemotherapy or the high leukocyte counts before chemotherapy do play a role in the prevalence of deep vein thrombosis and pulmonary embolism. And the requirement of surgery, especially in advanced cancers, especially in gastrointestinal surgeries and pelvic surgeries for cancer, and patients who require hospitalization because of advanced cancer, or sometimes in some chemotherapy, which can also lead to a higher risk of venous thromboembolism. And patients who already have comorbidities, especially they have a very high BMI, they do have a higher risk of venous thromboembolism. And the new concept of cell-free DNA, which is generally released after treatment, and we find that in the blood of patients, do have a role to play in the onset of venous thrombosis. And there is a risk scoring system by Corona et al., and which has found that the site of cancer, especially in stomach and pancreas, do play a high role of high risk for venous thromboembolism, and pre-chemotherapy platelet count, leukocyte count do have a role to play, and the hemoglobin of less than 10 grams has a higher risk of developing deep vein thrombosis, and a BMI of more than 35 does have a role of venous thromboembolism. And as you can see that the risk of venous thromboembolism starts lesser from the early stages of disease and then progresses as the disease advances. And there is a dual peak when during the initial periods of hospitalization for chemotherapy, et al., and they do have a higher risk. And again, towards the end of life, when there is a higher risk of metastasis and more metastasis, those patients are at a higher risk of venous thromboembolism. And as you can see that patients with pulmonary embolism picked up incidentally for a screening scan, or patients with symptomatic pulmonary embolism do have a similar poor dismal survival. So even patients picked up incidentally with the pulmonary embolism will require treatment for the pulmonary embolism to prevent complication. And as you can see, the venous thromboembolism and mortality does increase with the number of cycles of chemotherapy. And as you can see, there is a doubling in the risk for death among cancer patients with venous thromboembolism. And you can see the incidence of venous thromboembolism does increase even in ambulatory patients undergoing chemotherapy as the number of cycles progress within the first 3-4 cycles. And as you can see that the chemotherapy per se can contribute to the risk of venous thromboembolism, especially if the patient is on cisplatin or carboplatin chemotherapy, and if the patient is on L-asparaginase with ALL, even though they do have a low platelet count, those patients are at risk of venous thromboembolism. We should be careful. And patients who are on infusional 5-FU do have a depletion of protein C and increased thrombin activity, which does lead to a higher risk of venous thromboembolism. And breast cancer patients who are on tamoxifen do have a high risk of venous thromboembolism. And as you can see, in patients who have been operated for cancer, have a risk of venous thromboembolism even after going back home. So that is a very important factor to play. And as you can see, that pulmonary embolism is the single most common cause of death at 30 days after surgery for cancer. And as you can see, that patients who have been put on prolonged low molecular heparin do have a lesser risk of venous thromboembolism with the statistical significance. So we should consider extended prophylaxis with low molecular heparin for up to 4 weeks post-operatively, especially in patients with cancer who have undergone major abdominal or pelvic surgery. And ambulatory patients with cancer on chemotherapy, if they are at low risk for thrombosis as per the Corona scale, we don't have to put them on anticoagulation. But if they are at intermediate or high risk, that is 2 or more features, we need to put them on either direct oral anticoagulation or low molecular heparin. But if these two are not accessible, even a vitamin K antagonist is enough, especially if we can keep the INR at around 1.5. And patients with myeloma on thalidomide or lenalidomide would benefit with the addition of low-dose aspirin or vitamin K antagonist. And what is the aim of venous thromboembolism treatment? One, it is to prevent fatality. Next is to prevent recurrence, and also to prevent the thrombus extension and embolization. And the answer for all is anticoagulation. And as we all know, the old Clark trial did prove that low molecular weight heparin did reduce the risk of venous thromboembolism recurrence compared to vitamin K antagonist. It was also confirmed with the CATCH study where tinzaparin was compared with warfarin. And we all know with all the randomized trials that low molecular heparin was better than vitamin K antagonist. And what about the direct anticoagulants? The ones which act on factor 10A are rivaroxaban and apixaban, and on 2A is dabigatran. All these have been found to have a beneficial effect, especially in patients who've been admitted for treatment in hospitalized patients. But many of these studies which were analyzed, for the subgroup analysis, the Einstein DVT, Einstein PE, Einstein EXT, the Remedy and the Hokusai VT, all that did not have a high number of patients with cancer. The highest was around 6.8%. So most of them had less than 7% of patients with cancer. So even though there was some benefit, it was not really very catchy. And the Cassini and the Award were the main two studies which did find the benefit of oral anticoagulant compared to placebo with the occurrence of thrombosis, but they did have a slightly higher risk of major bleeding. So that has to be taken into consideration. But the most important factor which we need to consider in direct oral anticoagulation is the drug reactions with many of the chemotherapy drugs which we use. So we need to be careful in giving the proper drug and for the proper chemotherapy regimen which the patient is on. And the other factor which we need to consider, there are some ambiguities which are there with the direct oral anticoagulants with regards to tumor growth per se, because there are some studies where pancreatic cells were actually found to be hypertrophied, and some pancreatic cancer cells are also found post direct oral anticoagulation therapy in mice in the experimental mice. So that we need to consider. And there are some studies where lung metastases were also found to increase in mice vaccinated with melanoma cells treated with zimelanotide. So that also we need to consider before we decide on direct oral anticoagulation. But as of now, in clinical trials, it has not been found to be unsafe. It is reasonably safe, except for the drug interaction which we need to consider. So treatment of venous thromboembolism and cancer, we need to look at initial anticoagulation, which may be with low molecular weight heparin, like enoxaparin or dalteparin, or unfresh heparin, especially if the patient has renal dysfunction, and fondaparinux if the patient has a previous history of heparin-induced thrombocytopenia, and or rivaroxaban. And low molecular heparin, edoxaban, and rivaroxaban are generally given, especially in patients who have had history of venous thromboembolism for at least 6 months, and sometimes we can even consider it beyond 6 months if the patient is on active chemotherapy and has metastatic disease. So that we need to consider. Vitamin K and antagonists are generally inferior, but if both low molecular heparin or direct oral anticoagulants are not accessible, vitamin K antagonist is reasonably safe to use at lesser doses. So what we need to look at is the drugs which we give for hospitalized medical patients for prophylaxis of venous thromboembolism is either heparin or low molecular heparin. In surgical patients, again, it's either heparin or low molecular heparin. But in outpatient setting, we can also add rivaroxaban at 10 milligrams OD for prophylaxis. For treatment of established VTE, here there is heparin or low molecular heparin along with rivaroxaban at 15 milligrams twice a day for 21 days, and for long term, the rivaroxaban dose has to be reduced to 20 milligrams once a day. And like that, the other low molecular heparin doses are also modified for long-term therapy. So to conclude, if the patient has cancer-related thrombosis and there is a high risk of bleeding, if the patient does not have a tumor originating from the digestive tract or urinary tract, and the patient does not have any gross drug interaction between the direct oral anticoagulant and the chemotherapy, and the patient is not, and the thrombosis is not related to central venous catheter or the vascular port, we can safely consider direct oral anticoagulants like rivaroxaban. Otherwise, we can safely put them on low molecular heparin, and if that is also not accessible, we can put them on vitamin K antagonist. And we have to continue if the cancer is still active and metastasized, and the patient is going to be on chemotherapy, especially on cisplatinum or carboplatinum or 5-FU or tamoxifen, we need to consider long-term oral anticoagulation therapy. And so with that, I conclude my talk on on anticoagulation in cancer, and I thank the organizers for giving me this wonderful opportunity for having shared my views on oral anticoagulation in cancer. Thank you very much.
Very much, Dr. Devar Singh. I request you to stay around because the question session will be there. And to start with my co-panelist,
I thank all the presenters. It's a very good presentation. The topic also is very interesting topic. I thank the organizers also. These topics are very useful for our day-to-day practice. Thank you. It's very well presented by all the three presenters. Once again, thank you. First question to Indra Agarwal, Madam. Madam, you explained very in detail about pathophysiology in pediatric age group and adult age group. And management-wise, how pediatric anticoagulation, how it differs from adult patients, or what are the challenges you encounter during starting anticoagulation in pediatric age group? Please explain.
No, I didn't understand the question.
What are the challenges you encounter in the managing pediatric patients with anticoagulation when comparing to adult?
See, I'm not familiar so much with the problems you face with adults, but for children, generally we start on with enoxaparin and we shift over to warfarin quite quickly, is to avoid long-term use of, because it's a subcutaneous injection. And because of the risks of bleeding. We send the children home and we monitor the PTINR, but that allows us to send them home for say 4 weeks, 6 weeks, and we have established the INR. Sometimes it takes a little while to get the right level. So that is the most convenient method.
Okay, ma'am. Thank you, ma'am. Thank you. Next question to Pranay. Anticoagulation CKD. Pranay, there are two entities, CKD on dialysis and CKD not on dialysis. Is there any difference in starting anticoagulation these type of patients?
Yes, ma'am. There will be a significant difference because many times you do the HD, that amount of the pro drug or the drug which is used is actually excreted out and is removed out. FDA and according to all the other guidelines, ACCP, chest and all, so the approved oral anticoagulant is not warfarin in these cases. They actually found in 4, 5 and CKD5D, they found out that warfarin is harmful. Apixaban is probably the only one which is actually approved by all these places in these patients. Another thing, you have to repeat the renal profile of these patients often, every 2 to 3 months, and then after that accordingly adjust the dose. Most of these studies have used the creatinine clearance according to the Cockcroft formula. But what the nephrologists use, they use the CKD EPI for formula. So the clearances rates between the both of them are not the same. So that is also something which needs to be in mind as well.
Okay, thank you.
One small query for my knowledge.
Yes, sir. Yes, sir.
What is this new agent, denaperoid, which is coming for the management?
I am not this thing read about that all that much.
I just hearing about that, so I thought you have detailed.
So it's not approved in CKD for sure. These are the only drugs. Apixaban is the only one which is approved.
Can I have a question for Pranay?
Pride is no anti-diabetic.
There is a sort of a theoretical disadvantage of using vitamin K antagonists in CKD because these patients have medial calcification and vitamin K is essential to remove this calcium and take it back to the bone. So what is your opinion on that?
So it's an entity which is there for sure, and they actually say that within 2 to 3 years of starting warfarin, most of the patients, they actually have warfarin-induced anaphylaxis. And when that happens, and when you see it happening, they have skin changes and all, and ischemia can also happen. You need to stop it.
Okay, and switch over to the DOACs?
Yes, sir. Apixaban is the one which is the most
Because
often used.
I don't know what's the situation in most of the country, but at least in Ahmedabad, I can say that the orthopedic surgeons everybody is now prescribing vitamin K to their patients, K2, I mean.
Okay, sure.
So this is a change that I've seen over the last 4 or 5 years.
Sure, sir. Thank you.
May I get one question? My question is to Indira ma'am. Ma'am, I would like to know what was your protocol for COVID thrombosis in children? Was it any different from standard anticoagulation or the same?
We didn't actually come across too much of thrombosis in children, at least maybe as the ICU may have better statistics to give because we were not directly involved. At least we didn't find many children who had thrombosis. In fact, most of our COVID patients that we dealt with were actually incidentally COVID positive. We didn't really have sick COVIDs with thrombosis. I don't really have that data.
Any other question, please? So if there are none, we'll conclude this session. Thank you very much, speakers, for all excellent talks, and it was very illuminating. And thank my co-panelists for being there. With that, we close this session. Good evening.
Thank you so much. A big hand to all our chairperson and the panelists on stage and our speakers who joined along. Thank you.